A 42-year-old woman comes to the physician for shortness of breath and exercise intolerance for several months. She is 4 feet 8 inches, 147 centimeters tall, and physical examination reveals excess skin at the sides of her neck. She has a history of primary amenorrhea. Which of the following is the most likely explanation for this patient's shortness of breath? Choice A, high levels of LH and FSH. Choice B, narrowing of the aortic arch. Choice C, fusion of two aortic valve leaflets. Choice D, disrupted pressure gradient pulling mitral valve towards aorta. Or choice E, hypersensitivity reaction resulting from molecular mimicry by M protein. I'll wait 5 seconds and then answer the question. So this patient very clearly has Turner syndrome. You have the short stature, a webbed neck, and a history of primary amenorrhea. So that's pretty standard and straightforward for a diagnosis of Turner syndrome. And of course, you need to know that Turner syndrome is associated with various heart defects, including both bicuspid aortic valve and coarctation of the aorta. Now, there's a couple resources out there that seem to really like banging about the coarctation of aorta part and don't mention the bicuspid aortic valve for some reason. But you need to know that similar to the general population, it's actually more common to get bicuspid aortic valve in a Turner syndrome patient. Now, in this case, you have other things leading you towards that anyway. For example, this patient is older. She's 45, which means she's presenting a bit later, which pushes you more towards a bicuspid aortic valve diagnosis. So choice C here is the correct answer. I'll talk more about coarctation of the aorta in a minute, but just focusing on bicuspid aortic valve first. As the name implies, you have aortic valve usually has three leaflets, and usually what happens is that two of the leaflets get fused for some reason, which causes a bicuspid aortic valve. And even though everybody has some amount of calcification of the aortic valve over their lifetime, which can lead to aortic stenosis in very old age, people with a bicuspid aortic valve have it happen much sooner. So around age 40 to 60 is what's considered early onset aortic stenosis. And of course, the aortic stenosis can further lead to an outflow obstruction, which can eventually lead to left ventricular hypertrophy and diastolic failure. Aortic stenosis, of course, can present with a crescendo, decrescendo systolic murmur, best heard at the upper right sternal border, so the aortic area. And because you have aortic stenosis, a narrowing of the aortic opening, essentially, you can have what's called pulsus parvis et tardus, which is just a really convoluted way of saying you have a weak and slow pulse. So looking at some of the other answer choices here, first you have choice A, high levels of LH and FSH. So this is just me being a jerk to people who don't read the question carefully enough, and you just notice that it's Turner syndrome and you decide to just pick choice A. Obviously, high LH FSH does happen in Turner syndrome because ovarian failure leads to the lack of negative feedback, and then you'll have a high LH FSH as a result. But the question is asking about her shortness of breath, which of course has nothing to do with the ovarian failure directly. Choice B, narrowing of the aortic arch. So again, this is referring to coarctation of the aorta, and as mentioned, this is also seen in Turner syndrome. But usually, if they want to give you a symptomatic patient of coarctation of the aorta with a Turner syndrome patient, it's usually earlier on in their life. It also has a number of symptoms that you can look out for. It also has a systolic murmur, but it's an ejection murmur. It has upper extremity hypertension because when the aortic arch narrows, it's usually after the branches that supply the upper extremity. So you can do things like an ankle brachial index or even just measure the pulse of the ankle versus the upper extremity, and there'll be a obvious difference. And of course, similarly to bicuspid aortic valve or any number of heart problems, you're going to have the typical symptoms, shortness of breath, exercise intolerance. But in this case, you might also have a headache because of the hypertension in the upper part of the body. It should also be noted that from a practical perspective, it wouldn't really make sense to be talking about coarctation of the aorta in an older Turner syndrome patient because typically Turner syndrome patients will undergo early imaging. So coarctation of the aorta would be spotted early on, or it would be presenting early on, like I mentioned. So in a 42-year-old woman like this, it would be very strange to see them presenting with coarctation for the first time. Just not best answer choice here. Choice D, disrupted pressure gradient pulling mitral valve towards aorta. This is just kind of me going with a overly convoluted way of describing what happens in Hockham. In hypertrophic obstructive cardiomyopathy, what can happen is that the systolic anterior motion of the mitral valve, which worsens the outflow obstruction that was already present in hypertrophic cardiomyopathy because of the hypertrophy of the ventricle. In this case, Hockham is not a good answer because Hockham is not associated with Turner syndrome at all. Typical vignette for Hockham would be a young athlete, teens to even into the 30s. Sometimes they give you Hockham in patients in their 30s. And there's usually going to be some kind of family history of sudden cardiac death. And one other testing point they really like hitting on is the fact that Hockham has a systolic murmur that actually worsens with decreased preload. So, for example, if you do a Valsalva maneuver or you stand up and decrease preload, it actually worsens the murmur, which is the opposite of most left-sided heart conditions. Because in Hockham, what happens is that if you increase preload, what you do is that you increase the volume in the heart, and that can actually kind of push aside the obstruction caused by the mitral valve being pulled towards the aorta. Finally, choice E, hypersensitivity reaction resulting from molecular mimicry by M protein. Obviously, this is rheumatic fever, another high yield condition you need to know in and out. It's a type 2 hypersensitivity reaction usually following a strep pyogenes infection, so your strep throat or scarlet fever. And because of molecular mimicry, you will have autoantibodies against the heart valves. And early on, this can cause mitral regurgitation, and then later on in life, it can cause mitral stenosis. Now, rheumatic heart disease actually can affect the aortic valve, but it's pretty rare. And you want to be careful suspecting that sort of thing on step exam. If they want to give you rheumatic heart disease in the aortic valve, they will probably make it really obvious. So bring it back. You want to know that Turner syndrome is associated with both bicuspid aortic valve and coarctation of the aorta, but you do want to know that bicuspid aortic valve is actually still more common in Turner syndrome patients overall. It's just that they like testing on coarctation of the aorta a little bit more with Turner syndrome. So you just want to know the difference in symptoms between the two. Just remember that bicuspid aortic valve, it tends to cause narrowing or damage to the aortic valve over time, and then it will present a little bit later in life. That's not necessarily the case. There have been some rare questions, I believe, where they actually do test on bicuspid aortic valve in younger patients. So you don't want to completely rely on the age alone. But in contrast, coarctation of the aorta presents earlier, and it'll have hypertension in the upper extremities with potentially a decreased blood pressure in the lower extremities. And also, of course, be aware of bicuspid aortic valve itself being a relatively common congenital heart defect. I hope you found this video helpful. I'll see you in the next one.